Assalamu alaikum. Welcome to a new video on evidence-based medicine, evidence-based practice, evidence-informed decision making, and evidence-based decision making. The outline includes the concepts of EBM, EBP, and EIDM and EBDM, steps in EBM, and designing an effective research question using the PICOs. PICOs stands for Patient Intervention, Comparison, and Outcome. And there will be a quiz for you all, so you can pause the video and attempt the quiz. So evidence-based medicine, the definition says it's the systematic approach to clinical problem solving that integrates best research evidence, clinical expertise, and patient values and preferences. So it means the EBM includes all these three. Application is by physician and clinicians. They use in diagnosis, treatment, and prognosis. When they have to make decisions. So you can say it's the use is for clinical decision making by the clinicians. And for example, choosing the best antibiotic for pneumonia based on clinical trials, the evidence from clinical trials, and individual patient history. And there are some more examples which I'm going to discuss in subsequent slides. Evidence-based practice. The broader application of evidence-based decision-making across all health professions, including nursing, physiotherapy, and public health, that is called evidence-based practice. So when evidence-based medicine is specifically for the clinicians, for clinical decision-making, but evidence-based practice is throughout all the sectors, all the professions related to health, or you can say for all healthcare professionals, whatever kind of decision making they are doing, that is evidence-based practice. The component include best available evidence, clinical professional expertise, patient or population context, because not only patient, here population can come into the picture if we are talking about public health decision making or decision making for a larger group, then we can take the population context in that. And the application is used in day-to-day practice by various healthcare professionals and may include protocols, care pathways, and community interventions. These are a little broader, not just focusing on a patient or a specific patient, rather it is for a group and for community, in which we are developing protocols, deciding for the care pathways, and deciding and implementing interventions. In that case, we need evidence. We are actually doing evidence-based practice. Example could be a nurse using a pressure ulcer prevention protocol based on latest evidence. So it's that protocol is not just for one patient, it is for all the patients, for that unit or for that setting. So it's an example of evidence-based practice. Here I'm going to discuss the difference between evidence-based decision making and evidence-informed decision making. The definition: decisions strictly guided by best available scientific evidence, often from systematic research, clinical trials, or meta-analyses. While the evidence-informed decision making, decisions guided by a combination of best available evidence plus contextual factors such as an expert judgment, local data, resources, and stakeholder values. So the basic difference between both EBDM and EIDM is evidence-based decision making just based on evidence, while evidence-informed decision making is informed by evidence along with the contextual factors, in which there are multiple things that can be considered while making decision. Okay, the approach: hierarchical and rigid, prioritizing high quality research evidence above all else evidence. For example, if you can say you have seen the pyramid of evidence, the strength with increasing strength of evidence, when we go on the top of the pyramid, there is systematic review and meta-analysis. So in that case, this high quality evidence is more reliable as compared to a case control study or a cross-sectional design or case report. So the second part in this is evidence-informed decision making, in which the approach is flexible and pragmatic, integrating evidence with experience, context, and feasibility. So flexibility, if you say the approach is more flexible, more practical, more feasible. While the emphasis in EBDM is scientific rigor and standardized protocol. While in the EIDM, the adaptation and relevance to specific settings or population is also important. Application commonly used in clinical practice guidelines and protocols where strong evidence exists. But EIDM is often used in public health policy making and complex interventions where evidence may be incomplete or context dependent. So because this is a flexible thing and it involves multiple sources for decision making other than evidence. So yeah, here the application is more broader, and in a complex situation, this EIDM is more important than EBDM. Decision makers relies mainly on research findings from published study, while in EIDM they relies on research evidence plus practitioner expertise, stakeholder input, and real-world constraints. Example could be EBDM, the treating hypertension strictly according to clinical trial guidelines, while in EIDM, designing a community health program by blending research evidence, community preferences, and available resources, because this is going to be more practical and it is to be implemented for a community in a community program or at a community level. So here is an example of a super surgeon, a surgeon who is operating. There is an operative workload, there is administrative constraints and workload. This difficulty, there's a lot of research going on in his department or is part of that research. There's time constraint. There is cost related to EBM. He's not, it's not possible for him to, or it's not cost effective to pay for the databases or for subscription of journals or to appraised sites, the sites for, they are who are pre-appraised sites for clinical decision making, like up to date and BMJ best practice, etc. And there is a methodology and critical appraisal of the literature is also methodology is difficult task, uphill task. So in that case, here comes the role of AI and role of those platforms who can facilitate evidence-based medicine or and ultimately the evidence-based practice. When you look into the three components of evidence-based medicine, so first we are going to talk about mainly EBM, evidence-based medicine for clinical decision making, in which we start with patient values, what the patient wants, their preferences, their values, their socio-demographic, cultural context that should be known to the physician before deciding for the therapeutic or other interventions. So the second tier is the best evidence search. He will be searching for the best evidence for specifically for this patient, and it could be from any source through the paid platforms, or he can search the best evidence through systematic reviews and meta-analysis or the guidelines. And the third tier will be the clinical expertise, what the clinicians know, his own expertise in the field, his own observation, his own experience. So all these three, when these two combine and combined with the third one, uh, the clinical decision making is possible and is more contextualized and more meaningful. So here we start with assessing your patient and then making a clinical question about that patient, acquiring the best evidence, appraising that evidence, and applying that evidence. These are 5 A's of EBM that you need to know, and you need to actually, we all the discussion will be based on all these 5 points. So these are the 5 steps to evidence practice, and number one is the doing mode. Doing mode will be when we run all the steps and complete all the steps by ourselves, and we are the clinician is responsible to conduct all the steps. The using mode, a clinician can use a pre-appraised resources. Already the appraisal is being done and only he is just ready to apply And the using mode, this is the most commonly popular way of using practicing EBM. And then the replicating mode, seek expert opinion and just apply. And in this replicating mode, we, for example, senior consultant gives you opinion and you apply that, because that senior consultant, he has appraised all the evidence, he has gone through the pre-appraised resources, and he is ready to deliver it or to disseminate. So when you consult a consultant or a physician or a surgeon, and he is expert in his field, he tells you something, he tells you the solution of a research or clinical question, that is just the replicating mode, and you're just going to apply it on your patient. Pre-appraised resources for evidence-based practice. In we have system-based or pre-appraised resources like integrated decision support tools within electronic health records that provide real-time patient-specific recommendation. These are the integrated decision support tools. In the examples include UpToDate integrated in EHRs, the electronic health records, and Epocrates, Dynamet. When EHR integrated, it is more effective. So these are a few common examples which are in which the system integration is there. The other possibility or other you can say options for us are summaries. The evidence-based clinical guidelines and topic reviews that summarize evidence on a particular condition, they are available on UpToDate, BMJ Best Practice, Dynamed, Clinical Evidence, BMJ, and ACP Smart Medicine, in which these are the big platforms, or you can say the evidence, the platforms where these evidence are available, and they are the clinical guidelines are available, and topic reviews are available, and their summaries are available. So there you just need to go on a specific particular topic, and then you can find all the relevant recent data, the evidence. The third option will be synopses. Synopses, these are the concise summaries of individual studies or systematic reviews with expert opinion or appraisal. So these are also very important, in which you can specifically select one systematic review on the topic of your interest, and you can see how experts they are appraising it, or they are giving their comments on it. These examples could be Evidence-Based Medicine Journal, BMJ, ACP Journal Club, Dynamed Summaries, and Journal Watch, in which published literature is being commented upon, or it opine, and you can say the rapid responses are there in these journals and these platforms. Okay. Syntheses, systematic reviews and meta-analysis that combine results from multiple studies. They are called the syntheses, or synthesizing studies, or synthesizing evidence through these studies. So we have Cochrane Library, we have PubMed Clinical Queries or Systematic Reviews, JBI Evidence Summaries, and healthevidence.org. These are the platforms where you can find systematic reviews and meta-analysis summaries. And from here, you can select any recent evidence for your journal club and later on for your research. The fifth one, in which we directly go to the studies. These are not pre-appraised but included for comparison. For example, RCTs, cohort studies, and the platform providing access to these studies are PubMed, Google Scholar, and Embase, in which you can approach these studies, you can read these studies and identify the evidence relevant to your need. Okay, so why to use pre-appraised resources? Appraisal, I hope you understand what is appraisal. To critically appraise a study for the qualities, for the standard, and for scientific and ethical soundness. So there are appraisal checklists available, and I will be discussing critical appraisal of medical literature in another video. But here you just need to know what pre-appraised resources are. Those are appraised by experts, and scientists. So these resources can save time and effort in critical appraisal. They use of high quality filtered evidence and supports faster clinical and policy decision. So these are the benefits of using pre-appraised resources rather than going for appraisal using the checklist and doing the appraisal yourself. AI tools, they're not prepaid resources. Okay, so prepaid resources are Cochrane Library, UpToDate, Dynamed, etc. They involve a human expert review, formal methodological appraisal, and transparent grading of evidence. So AI tools, they are not currently they are not doing that. AI tools don't inherently appraise the quality of studies unless designed to do so using structured data. So till now we don't have such kind of AI tools who are praising the evidence for us. But later on, over a period of time, we might be getting those. How AI can support access to pre-appraised evidence. There are ways how we can use AI to support pre-appraised evidence, like the search optimization. AI enhanced search in PubMed, GPT, elicit.org. You can have a AI enhanced search, and this speeds access to systematic reviews guidelines. So this is the basic advantage of search optimization. Summarization, ChatGPT cites semantic scholar, TLDRs, etc. They offer plain language summaries of complex reviews and clinical guidance. If you are it's difficult for you to understand what complex paper is this and a lot of stat is there, then you can use these AI tools to summarize it, to make it in a plain language, and even you can have audio option to listen to those reviews. And then we have the third thing is critical appraisal assistance. When you are doing the critical appraisal, you can use elicit.org, litmaps, a research rabbit. These are AI tools that can help sort and rank studies. Some tools extract PICO components for you, for example, SciSpace. It can help you identify the population in the paper, the intervention, comparison, and outcome mentioned in the paper. So it gets easier if you use AI wisely. Evidence tracking, connected papers, lit maps, AI enhanced. Zotero is also there. Zotero is also used as EndNote and Mendeley for reference management, and it's also providing it's AI enhanced for evidence tracking now. So visualize study clusters around high quality sources. So if you get one high quality journal, one high quality paper, you can cluster other studies which are referenced within that paper or connected with that paper. So it's very useful thing to use AI for this purpose. Limitation of AI tools as evidence sources. They are not peer reviewed or guaranteed accurate, can hallucinate citations or misinterpret context, may not grade evidence using grade or similar standards. Uh, the best practice is AI plus using pre-appraised resources. And to use AI responsibly in evidence-based practice, start with pre-appraised resources like Cochrane Library, UpToDate, or Dynamed, or JBI. Use AI tools to summarize findings, extract PICO elements, generate patient education material. For example, or you can say how you're going to counsel the patient, or patient education material includes everything that you are going to tell the patient. They can be in any language, even ChatGPT can help you, or any AI tool can help you to formulate it in any language, and even as audio as well. So always verify citations and clinical accuracy. Check if the AI is linked to curated databases like Cite AI uses citation context from published literature. So you have to check what kind of AI you are going to use. Try to use AI linked with curated databases. So we have AI tools supporting pre-appraised evidence. Elicit.org, this is an AI assistant that finds and compares studies using structured prompts, like it supports PICO and getting a review of a paper. Cite.ai shows how a study cited, supporting or contrasting, helpful for judging reliability. So it's good to have a balanced literature review of both sides to help you decide in your clinical decision making. Or consensus.app is also, it provides answers scientific queries with cited evidence summaries, mostly from peer reviewed sources. So it's also good because these are peer reviewed sources that are linked with the consensus. PubMed GPT, it's experimental under trial and AI interface for summarizing and querying PubMed article. PubMed is actually working on using chat this GPT with that, and in which we can get the summary of peer-reviewed evidence and good quality evidence. So here is the hierarchy of evidence in which you have test tube research, animal research, ideas, opinion, editorial, then case report series, cross-sectional studies, case report, control, cohort, randomized control trials, systematic reviews, and meta-analysis. These are with increasing strength. These are the studies with least strength, and these are the studies with highest evidence strength. So with increasing evidence strength, we are more confident in the evidence that is which shows more strength because it is from a study that is a systematic review or meta-analysis or an RCT. So we are more confident in such kind of evidence. Here you can see these are the studies which have unfiltered research, for example, expert opinion, case controlled study, case series, reports, cohort studies, randomized controlled trials. These are unfiltered research. And the filtered research include critically appraised sources, systematic reviews, and meta-analysis. The same evidence hierarchy, but in context of what kind of evidence is it, a filtered research evidence or is unfiltered research evidence. So on the basis of that, before decision making, we will prefer using meta-analysis, systematic reviews, and critically appraised sources. So in this category, we have Cochrane database of systematic reviews, Prospero that registers all the systematic reviews and meta-analysis. We have TRIP, we have systematic review filters in Medline, SynHall, then Psych Info, etc. There are multiple so resources for that. Up to date, EBM filter, clinical evidence, ACP Journal Club, these are all critically appraised resources. Now, for this, the RCTs for the independent studies, cohort studies, we can use subject databases, citation databases, Central, Cochrane, or TRIP. And we have clinical textbook and manuals for these expert and background information. Now, these are the few questions. By looking at the question, we can identify what kind of study design best fit for this. And we can search those studies. If we have a clinical question in mind about which diagnostic test should I select or you select, and how should you interpret the results of that test, in that case, you have to look into the literature about cross-sectional studies done for screening, in which there is a comparison with gold standard. So you can say you can get an idea of the test in which you are interested in. In therapy, which treatment will be the most beneficial and worthwhile for such kind of clinical question? You need to look into RCTs done to answer this question. Randomized controlled trials. Okay. Then comes the prognosis. In prognosis, how can you predict the likelihood of a particular outcome for your patient? For example, in a particular patient, you want to make a decision, you want to predict the outcome and what is the likelihood of a good outcome, that you can study from the literature by looking into the cohort studies or case control studies. These studies are for association, prediction, and relationship studies. Okay, for etiology, how can you determine the cause of a disease? Such kind of question can be answered through cohort studies. So if you have such kind of a clinical question, then you will look into the cohort studies in literature. Here comes the PICO that we are talking about. This is an acronym used to help formulate a well-defined searchable question. PICO, P stands for patient, population, or problem. What are the most important characteristic of the patient and their health status? Is for intervention or exposure. What main intervention are you considering? Medical, surgical, or preventive? So C is for comparison. What are the alternative benchmark or gold standards being considered, if any? O is for outcome. What is the estimated likelihood of a clinical outcome attributable to a specific disease, condition, or injury? So we are going to see the practical examples in subsequent. In patient with a history of myocardial infarction, is rivaroxaban better than placebo at reducing cardiovascular related mortality by 2 years? If you apply PICO on this, what will be your P, population or patients? Patients with a history, P is the patient with a history of myocardial infarction. And what will be the I? I will be rivaroxaban. And what will be the C, comparison? Yes, there is a comparison, placebo. And what is O? O is the reduction in cardiovascular related mortality. And there is a T as well. So sometimes we have the option of P COT. COT T is for 2 years. So in this way, you will dissect your question, apply the PICO or PCOT, and in subsequent slide, I will give you time so you can pause and think of the answer and then reply. See the answer. So example 2 is a mammogram more accurate than an ultrasound at diagnosing breast cancer in women between the ages of 20 and 30 with a family history of breast cancer? So for this, what will be the P? Woman aged 20 to 30 with a family history of breast cancer. Good. I is the mammogram. Good. And what about O? For C, sorry. C is ultrasound. And O, good. Accuracy in diagnosing breast cancer. So very good. So coming to the next question. In women who are less than 30 and sexually active, how does Gardasil compare with the current standard of care at reducing the incidence of cervical cancer by the age of 50? So what is P in this case? Good. Women less than 30 years sexually active, they are. This is the population or patients. What about I? Gardasil. Good. C, current standard of care. Comparison is with current standard of care. Very good. And what about O? O is incidence of cervical cancer. Very good. T is also there. T is by age of 50. Good. Does high hemoglobin increase the risk of pulmonary embolism in mobile patients over 5 years? So this is a little bit, you can say, a different. What is P in this? Mobile patients. Good. And C is high hemoglobin. Okay. And I, is there I in this? T is there, 5 year. No, there's no intervention. There is no I, so you are not supposed to write I. Okay. So coming back to the cycle again, 5 A's. Assess, ask, acquire, appraise, and apply. So we have done assessment and ask, two things. And acquiring the evidence, we have looked into the AI tools, we have looked into the best practice pre-appraised evidence, pre-appraised sources. So next, the appraisal part, that appraisal part will be covered in critical reading of medical literature. There are critical reading checklist, appraisal checklist that I will be discussing in another video. Okay, thank you. And the another video, third video will be on applying the evidence to patient care. So thank you very much. Have a nice day.